Hello everyone, I'm Dr. Rita Roy. Welcome to Spine Talks, where we bring unparalleled access to world-class experts. Today, I am delighted to be joined by Dr. David Pauly. Dr. Pauly is the Chief of Spine Surgery at the University of Minnesota. He is an illustrious and celebrated spine leader for many, many years, and it is truly an honor to have him taking time out of his busy life to be with us today. I'm going to ask Dr. Pauly to introduce himself.
Well, hello, Rita. Great to see you.
Thank you for being here.
So, my background is that I started at the United States Military Academy at West Point and served for 2 years as a line officer in the Army Corps of Engineers. I had the privilege of jumping out of airplanes and wandering around through Army Ranger School before going back to medical school. I went to the Military Medical School, the Uniformed Services University of the Health Sciences in Bethesda, Maryland, and then trained at Walter Reed. I did a spine fellowship at the University of Minnesota, and then came back to Walter Reed, where I was the Chief of Spine Surgery for approximately a decade, and then Chair of the Department of Orthopedic Surgery and Rehabilitation. I then got asked to go back to the University of Minnesota as the Chief of Spine Surgery, and I've been there for 20 years or so.
You have served in many leadership positions in evidence development and in professional spine societies. I think along that way you've been president of the Scoliosis Research Society, which is a legacy society in the spine world. Am I forgetting anything else?
No, I've had the privilege to serve professional medical associations in a number of capacities. The Scoliosis Research Society is probably the thing that I'm most proud of, and that the goal of the Scoliosis Research Society is to foster the optimal care of spine patients of any age. Mm-hmm. And so that's something that I could really appreciate.
We are also joined today on the panel by Lindsay Arash, who's the Director of Research at the National Spine Health Foundation. And Lindsay is a highly trained surgical spine physician's assistant and spent many years in the operating room. Lindsay, can you tell us a little bit about your background?
Yeah, so about 15 years as a physician assistant, working mainly over a decade in spine surgery, taking care of patients in all aspects of their preoperative, intraoperative, and postoperative phases, really understanding what's important to patients. Then I transitioned to a research career and have been working on developing and sort of proving and then looking at what works best for patients.
Wonderful. Well, so today we are going to be talking about a topic that's actually very hot for a lot of people in wanting to understand where their back pain is coming from, and specifically their low back pain. Dr. Pauly has published a lot, has done a lot of research and a lot of experience with patients who suffer with low back pain in terms of looking at, does their back pain actually come from their spine, or does their back pain actually come from their hips? What we're talking about is a part of our anatomy called the sacroiliac joint, the SI joint. So we're going to just have this conversation. And Dr. Pauly, I want you to tell me why you think this is such an important topic for us to discuss and to educate the public about.
Great question, Rita. So I've been a firm believer that we need to shoot at the right target in order to have a chance to hit it. If we shoot at the wrong target, we're absolutely not going to hit it. And the challenge is that for low back pain, it can come from the back, it can come from the hip, or it can come from the SI joint. So I was trained in the early 90s how to do an open SI fusion, and I couldn't make it work very well.
And can you tell us what that means? What is an open SI fusion?
So it's a big incision, taking down muscle, taking bone away from the SI joint across the outer table of the ilium, or the outer part of the pelvis, and then grinding it up and putting it in, and then having the patient's limited weight bearing, so crutches or not walking for a while, to try to get the joint to heal. Mm-hmm. And the morbidity associated with that was kind of substantial.
And that means, morbidity means?
The pain and suffering from it. And so that I stopped doing SI joint fusions at Walter Reed because I couldn't make them work.
Yeah.
I could make the diagnosis and I would just send the folks for physical therapy because my surgical ability to fix the problem was not good enough. I also had a labral tear in my own hip and got very insightful about differentiating hip pain from back and SI joint pain. So I used to make the diagnosis of labral tears about 50 times a year in people coming through my spine clinic. So I really got focused on, is the pain coming from the back? Is the pain coming from the hip? Is the pain coming from the SI joint? And that requires a sophisticated physical exam and oftentimes selective injections or blocks. And so I try to tell my patients, it's like the dentist numbing up your tooth. Did we get the right tooth? It's not going to fix the tooth, but it's going to tell us which tooth is the problem. And so that's the challenge for us. 15 to 30% of all low back pain actually comes from the SI joint. And so if we are operating only on an MRI of the lumbar spine, they may have black disc disease and they may get a fusion for it, but that may in fact not be the problem. And so understanding how to figure out where the pain is coming from is absolutely critical to being able to shoot at the right target and then potentially help make the patient better.
And do the right procedure. And maybe we should talk for just a second about where the SI joint is in the body, and how closely aligned it is to the lower back, to the lumbar spine.
So the spine comes down and joins to the pelvis, and the spine has to transmit all of the load of the upper body through the sacrum into the iliac wings, that then goes into the hip and down to the floor.
So this is the pelvic bone, right?
Well, so the pelvis is made up of several bones. This is the sacrum here in the middle, and then this is the ilium.
And so, hence the words
Sacroiliac joint. So we're not very creative in naming joints. And so where the ilium comes into the sacrum, right here, that's the sacroiliac joint. And from the back side, classically, we think about the posterior superior iliac spine as representing where the SI joint pain typically manifests. So what we do in trying to understand is the pain from the hip or from the spine is we load those joints. Well, to load the SI joint, we have to put a torsional load across the pelvis. And we do that with 5 specific maneuvers. And if 3 of those maneuvers are positive, i.e. reproduce the patient's typical pain, then we have an 85% probability that that's where the problem is coming from. To confirm that, we'll get an image-guided injection of local anesthetic into the SI joint to let us know if that relieves the pain.
identifying the source of the pain is the first step in treatment.
Absolutely. And then once we've identified where the pain is coming from, then we typically start with non-operative treatment. So physical therapy will be key. Non-steroidals may or may not be helpful. Sometimes an SI belt will help. So an SI belt is kind of like a cargo strap that goes below the brim of the ilium, above the hip joint, and it tries to cinch it together so that it doesn't move.
Yeah.
The SI joint only moves about 1 to 3 degrees in this motion, and it moves enough to hurt. And so that's the challenge for us, is not are we restoring or maintaining motion, it's are we causing pain.
And so when you are evaluating people who are coming in with this lower back, kind of in the hip area pain, do they always get x-rays, or what kind of imaging studies should people get or expect to get?
Right, so typically plain film imaging or regular x-rays is what we start with. So if we see obvious hip arthritis, then that points us in the direction of the hip joint. If we see obvious spine anomalies such as scoliosis or spondylolisthesis, which is where a vertebra slips forward, then that will direct us more to turn right or turn left versus go straight.
Yeah.
Usually, for most patients with SI pain, the x-rays of the pelvis are essentially normal. So it's really a diagnosis based more on the physical exam and then confirmed with the diagnostic injections.
That's really fascinating. And so spine experts have to really understand how to do that physical exam.
Yes, they do.
And is that something that has come along? Is that a relatively new thing, or is that commonplace? Or what would you say to patients who are struggling to identify where their pain's coming from?
Yeah, so over the years, there's been a lot of debate does the SI joint even have the capability to hurt?
Yeah.
And that there have been wonderful anatomic dissections demonstrating pain-sensing nerve fibers within the joint,
Oh.
as well as in the anterior joint capsule, as well as in some of the posterior ligamentous
Okay.
complex.
So there's actually nerves that can
Sense pain.
sense pain.
Yes. And so then the next piece is that the physical exam maneuvers, I think, have been well understood by the physical therapists and perhaps the manual medicine community, such as chiropractors or osteopaths, but not so much by the allopathic or MD community. Perhaps in the discipline of physical medicine, there's a little more attention to it. In the surgical community, it's only recently that we started paying attention to that. So a couple of things have happened. Techniques for doing the surgery have evolved from the big open surgery that I was initially trained on to minimally invasive techniques where the collateral damage or the disrupted tissue from the surgery is much less. So it used to be gallbladder surgery was a big open incision,
Shark
and
bite.
now it's done through video technology.
Belly button surgery, they call it. Yeah.
Well, or I like to say poke hole surgery, but yes. And that that with the advances in the minimally invasive techniques, the collateral damage or the other tissue damage associated with the surgery has gotten much less. And we've had the development of really high quality data demonstrating the benefit of surgical intervention in appropriately selected patients.
Yeah.
So
That's that. You said that very quickly, but that's the key. That's about finding the target and hitting the target.
yes.
The appropriately selected patient.
Yes.
Yes.
And so the appropriately selected patient is someone who doesn't have obvious hip disease, obvious spine disease, has 3 out of 5 positive physical exam maneuvers and responds to the injection and hasn't responded to non-operative treatment.
Yeah. Okay.
And when that is the patient that I'm seeing, I can tell them that I have an 85% probability that I'm going to cut their pain in half. And if I have an 85% probability that I'm going to help them, that means I have a 15% probability that I can't help
You
them.
can't. Yeah.
So,
Well, for women who are in childbearing years and have children, the structure of the pelvis changes. It expands to accommodate a growing baby.
well, the way I would phrase that is just slightly different, is that in the 3rd trimester of pregnancy, we know that the woman's body secretes relaxin. The goal of relaxin is to relax the ligamentous complex so that the pelvis can gap open for vaginal delivery.
Right.
And that once that relaxin has softened up the ligaments, they never quite get to be the same again. And so probably 2/3 to 3/4 of patients who present with SI pain are women, and so that they are more at risk, especially associated with pregnancy.
That's so interesting, and I would have thought that, but it's amazing to hear the actual observation, the clinical observation on that. And do you find women who've had multiple children are more likely to have SI joint issues
So that's
later in life?
That's
or?
a great question, and we don't have clear data on that.
Yeah.
We only have clear data that there's a strong predominance of women having more SI pain than men, although certainly a large number of men have it as well.
Yeah. Yep. Yeah. That's so interesting. Are there things that women who are, have just delivered a child, or they're just, in those early sort of months and weeks postpartum, are there things they can do to strengthen the SI joint or to support it as the body is reshaping itself?
Great question. So there's been a lot of work in the Scandinavian countries trying to understand postpartum pelvic girdle pain is the terminology that they use. And that other than specifically directed physical therapy, there's not a clear answer to that. And it's also not clear why some women are substantially debilitated and others are not.
Yeah.
So we don't have a correlation with, say, weight gain during pregnancy or necessarily pelvic morphology.
Can't quite. It's different for each person, right?
Yes, we
No,
don't.
no cookie cutter solution there.
We don't understand the specific risk factors
Yeah.
that cause someone to have it and someone to not have it.
Yeah. Lindsay, you were sharing with me that your experience.
Yes,
Can
I
you
do
talk
have
about
a
that?
personal story
Yeah.
that this rings so true for me. I have 3 children, but after I delivered my first son, he was a big child, 8 pounds, 7 ounces. And during the pregnancy, I had no SI-related pain, but immediately after delivery, I just had this terrible back and buttock pain on one side, and I could barely walk. And at the time, I lived in a condo where I had lots of stairs, and so carrying that carrier, you have to get the baby to the doctor like 2 days later,
All the
or
time.
once every week, and they have to get all these shots, and so I'm carrying this carrier, and it's so awkward, like the way that you carry it. It's a heavy baby, and I could barely put weight on it, and I just thought, oh my gosh, what happened? And then finally, after about a week of suffering, my PA brain kicked back in, and I thought, oh my goodness, it's my SI joint. So I immediately called a physical therapist that I knew. They brought me right in, put me on the table, examined me, and I can remember this so distinctly, and this was now about 12 years ago. I was laying on my stomach, and he took my foot and just popped my leg, and it immediately felt better. I mean, it was just restricted. It wasn't in the right alignment. He realigned it, and I walked off the table, and I thought it was a miracle.
That's incredible.
And I know that that's not necessarily the experience that everyone would have or should expect, but that was a miracle for me. And then I was able to walk and care for my child, and it didn't actually happen with the other pregnancies.
Yeah.
But that was an amazing situation.
Yeah, so the complexity of the SI joint makes it a little bit harder to understand. The hip joint's pretty simple. It's a ball and socket, and we all kind of understand that. The SI joint is a series of hills and valleys, and it moves a little bit, and we think that sometimes it, for lack of a better medical term, gets out of whack. And so when we have hill-to-hill point loading, that probably results in higher contact stress, resulting in more pain. And so you had a manual therapy strategy that got the hills back to the valleys and gave a greater surface area for load distribution. And when that works, that's spectacular.
Yeah.
And the challenge is sometimes it does and sometimes it doesn't.
Yes.
So when a patient has gone through physical therapy and they've gone through injections and all of the non-operative things, you've identified that the pain is coming from the SI joint. What are their next options?
So typically, we have to assess how limited they are by what's going on. And so there's some people who, yeah, it's a bother, but it's not bad enough to have surgery. And others are, my life is disrupted and I can't go on like this. And so probably the best tool that we use to assess how much impact it's having on their life is something called the Oswestry Disability Index questionnaire. And so if you want to know what that is, you can just Google Oswestry, OSWESTRY, and it will tell you it'll give you the actual questionnaire and tell you how to score it. And it says, because of my back, I can't do certain things. That's scored from 0 to 100.
Okay.
0 is the best possible score, 100 is the worst possible score. Typical people undergoing SI fusions are in about the 40 to 60 range, probably averaging about 50 in our clinical trials. And so that indicates a degree of disability that probably merits the intervention. If you're scoring in the 20s, probably not.
Yeah. And Dr. Paula, you talked about an SI fusion. So that means that you are fusing the joint.
Right, so the SI joint has that little bit of motion, and the concept then to eliminate the pain is to eliminate the motion. The most studied technique involves putting lateral to medial implants coming in like this under image guidance or X-ray guidance technology and putting implants across the SI joint like this. Those are the ones that have the most literature support for studying it. There are several other techniques that have been reported, but the highest quality literature comes from the lateral approach, typically with a triangular bone ingrowth implant. The technology of the implants continues to evolve, but putting that kind of device across especially if it's a bone ingrowth or on-growth device, can give very durable results. So we have prospective data that people who get better with the surgery, we know from following them that that surgery is durable out to 5 years. We just haven't followed groups longer than 5 years, but there's no reason that it should get worse.
Right.
Now, not everybody gets better, but if you do, it appears that the results are quite durable.
And Dr. Paul, you talked about the nerve endings that are in that SI joint that can detect pain. And is it the movement that somehow fires off those nerves that causes the pain, and that's why you want to fuse it so that there's no motion?
Well, so I think that's a great question that I don't know the answer, and I don't think we in medicine fully understand that answer. My way of trying to understand that is a load transfer piece. So if you overload something, you stimulate nociceptive fibers to generate pain signals. And so when we have the appropriate alignment, we have a large surface area to distribute the load. If we're out of whack and we get point loading, then we're probably getting overload of the cartilage and the subchondral bone, so the bone right underneath the joint, that is where the nociceptive or pain-sensing nerve fibers live.
Yeah.
And so I think that's how we trigger it.
And
There's one other question that I would love to hear your thought process on. Because the pelvis is a ring, and generally you're fusing one side of the one SI joint, we have two. What do you think happens to the other side? Do you think it moves more? Do you think it really just has no bearing on the fact that we're fusing one side? Is there a counter effect to the other SI joint?
Right. So understanding pelvic behavior is important. So we have two SI joints, and then we have a symphysis pubis. And so while it's a ring, it's not quite totally rigid. And so that we have a little bit of motion like this, and then the other side moves as well. And they move a little bit normally with normal gait and normal activities. What I can tell you from finite element modeling is once one side is fused, it doesn't seem to affect the range of motion of the other side. Now the challenge for us is the motion that we typically think of, flexion extension, which in the SI joint is called counternutation and nutation, is just 1 to 3 degrees. So that's a hard amount of motion to pick up. What I can say is that the clinical experience is about 1/3 of my patients end up needing both sides done. And so that really is sort of the clinically pertinent question. And then the other thing that we know is that up to 40% of patients who end up going on to have SI fusions have had previous lumbar fusions to the sacrum. When we fuse L5 to S1, we increase the motion of the SI joint by 50%. When we fuse L4 to S1, we increase the motion of the SI joint by 168%.
Wow.
So
Wow.
that's a significant increase.
And just to understand that for a second, that's because those vertebrae that are fused, that are right above the SI joint, are pulling more on the joint? Is that how you would describe that?
So when we lock the sacrum so that it can't move and the lumbar spine can't move, that then means the load has to go somewhere. And so it then, as it's being transferred through the pelvis to the hip joint, that there's greater stress across the SI joint itself because the lumbar spine can't accommodate that anymore.
Because it's moving as one solid piece at that point.
Right, so for the engineers in the audience, there's two kinds of ways that testing is done: load control or displacement control. Load control means that you have a constant force applied and you look at how much things move. Displacement control means that you set amount of displacement and you measure how much force or how much load is required to cause that displacement. I think life is displacement control mode, so that if you have to put on your shoes and socks, you have to get down to your feet to
Right.
be able to do that. And whether it takes more force or less force, you still got to get to your feet.
Yeah.
And that if you have less motion segments to move, that means that more force goes across those remaining motion segments.
As we age over time, we tend to lose balance, right? And that's just sort of part of the natural aging process.
Do you mean become unsteady or less steady?
Yeah, a little less steady. And if you've got, if your SI joint is fused, how does that affect your balance as you as you age? And do you see differences in that?
So that's a little bit of a hard question in that the amount of motion across the SI joint is really pretty small. That's more, I think, impacted if you have more segments in your spine fused. So I'm not sure that we've been able to discern differences in motion patterns between those with and without a fused SI joint. In a very sophisticated gait lab analysis, maybe we could pick that up, but in general, in observational gait analysis, we're not going to see enough change to be able to accurately discern that. Now, what we can see is when you have an abnormal gait because it hurts so bad that the patient is very limited, and then when we restore the SI joint either through manipulation or fusion, that the gait pattern returns to a much more normal appearing gait pattern.
One of the things that I think is so important is to help patients understand that the anatomy is complicated, and that thinking about the pain that's in their lower back could be coming from their hips. And we've talked about ways that we can determine where the pain is coming from so that we can find the right target. What would you say to patients who have failed non-operative treatment? So they've had an injection, they still have the pain, they don't want to have surgery. What would you say are their options to get through their life? And they say, the pain is really bad, it's stopping me from doing things, but I don't want to have surgery.
Well, it's a quality of life choice. So this doesn't kill anybody, it doesn't paralyze anybody, it just hurts. And the question is, how bad does it hurt? And that, we always start with the lowest risk strategy and then escalate risk depending on the response to the initial treatment options. And so if someone says, well, it hurts really bad, but it doesn't hurt bad enough to have surgery, my response is, okay, come back when it hurts bad enough that you want to have surgery.
Yeah.
And that, it's what are the things that cause people to want to have surgery? Can't sleep at night, very big, profound changer in people's lives. Unable to do activities of daily living. If you can't make it walking to the bathroom, that becomes profoundly limiting. And then other people have different thresholds.
Yeah.
And so I can't run 26 miles a day. Okay, am I going to get you back to doing that? Well, maybe, maybe not. But it's sort of what is acceptable or unacceptable to that individual.
Yeah, so returning to their pre-existing state, like what the expectation is for the patient. Yeah.
Right, and again, I think the key piece is that 85% of the time we can reduce their pain scale on a 0 to 10 scale by 50%, and the Oswestry Disability Index, we can reduce that by about 50%. And so that's been pretty consistent. And so with that, you have to sort of say, okay, are you hurting bad enough that that amount of change is worth it for you for the surgery? And that's where the collateral damage or the invasiveness of the surgery matters. So this surgery typically takes me about 45 minutes to do.
Wow.
So typically lose...
This is very different than what you were originally trained to do back in those days.
Yes, and we typically lose 20 to 25 cc's of blood.
So it's a tablespoon?
2 tubes of blood in the lab, maybe 3. And
so what does that measure into household measurements? A tube of blood is 10 cc's?
Yeah,
So
7 to 10.
Yeah.
Yeah. And so it's insignificant and almost immeasurable. Then the next piece is the people go home same day, and they're typically on crutches for about 3 weeks.
Okay.
And so
And they go home the same day.
Yes.
That's incredible. That's a miracle.
Well, it's certainly been an advance over what I was originally trained in. So
Yeah, for sure. I would say so.
Do you have any experience on how well injections do for people, or if people do well with injections, are they candidates for radiofrequency ablation or some regenerative medicine injection?
So great questions. The variability in the way injections are done make it a little bit difficult to give a uniform answer to that. So that I think the injections need to be done in an image-guided fashion, and that they need to be done in a way that we only want to put about 1.5 to 2 cc's, which is a very small volume, into the SI joint, because that's all it holds. If you put any more than that, it's sort of flooding out of the SI joint and going who knows where.
Yeah.
And so if I have an injection that doesn't make sense to me, i.e. the physical exam is positive, but they didn't respond to the injection, it makes me question, was the injection done correctly? And so I have a low threshold to get a CT-guided injection done. With a CT guidance, I know the needle is exactly in the joint and that the injectate is going into the joint. And so that then is helpful. 2 kinds of injections, diagnostic and therapeutic. Diagnostic is the dentist numbing up your tooth, so it's a local anesthetic, and that lasts minutes to hours. A therapeutic injection is typically local anesthetic and steroid. And what steroid does is if there's an inflammatory process going on, it doesn't change the mechanics of the joint, but it knocks down the inflammatory portion of what is causing pain.
Mm-hmm.
And so the inflammatory portion, like if you get a bee sting and you get the swelling, that's an inflammatory response.
Mm-hmm.
Some patients get significant, longer relief, but most patients it's less durable benefit. And so it's been rare for me to see patients in my clinical setting where injections alone are adequate. You asked about PRP, and certainly that's been a hot topic, especially in the sports medicine world. I'm unaware of any high-quality data indicating that PRP in the SI joint makes a difference. I'd love to have it be an answer that works, but
Yeah.
we don't have data saying that it does at this point.
And
in time.
PRP is platelet-rich plasma. Is that true for stem cell as well? So stem cells are slightly different than PRP.
So a lot of this kind of stuff has been tried, but it's not been tried in high-quality scientific trials so that we can say, does it work or does it not work?
Right. There's anecdotal
Right.
stories, right?
Right.
So there's enough to give people an idea that maybe they should try it, but we're saying we need to be careful about looking at that option.
Well, what I would say is that you're generally not going to find insurance approval coverage for it because there isn't sufficient medical evidence to say
Okay.
it works.
Yeah.
If someone wants to have that done, as long as it's done by a practitioner who practices good sterile technique, it's pretty low risk, but it doesn't have demonstrated high potential at this time to show significant
Yeah.
improvement.
Yep. I like what you said there about having the right practitioner deliver your care. And one thing that we get a lot of questions about is, how do I know I'm at the right doctor for the problem that I'm having? And there were so many things that you talked about, the image-guided injections. To have that done, that means you've got to be at a qualified center in the hands of a very qualified expert. Can you share with us what kinds of doctors patients should find to pursue this kind of treatment?
So what I tell my patients, so I have folks in the Midwest, some of them come long distances. So I have some folks who come to see me from western North Dakota, and it may take them 10 or 12 hours of drive time to get there.
Wow.
Usually flares their SI joint.
I was going to say, they're probably in worse pain.
And so when they say, how do I find someone to do this kind of an injection for me? I said, well, the best answer I got is call up the place that might be able to do it and say, how many of these do you do a week? And if they say, what kind of injection? Say, thank you very much, have a nice day. If they say,
yeah.
we do 20 of these a week, then you're probably in a place that knows what they're doing. Other than that, it gets harder. So injections can be done sometimes by surgeons, by radiologists, by pain doctors, and now even family practice sports medicine doctors are doing injections.
Into the SI joint.
So the SI joint is more challenging than most, so a lot of injections now are done with ultrasound guidance. not clear that ultrasound guidance works so well for the SI joint. So that means it usually needs to be done under x-ray guidance, which means that they have to have an x-ray setup within their clinic. And for me as a treating surgeon, I want to see the picture of the injection.
Yeah.
And so if they can't save the image so that I can assess the quality of the injection, then oftentimes I'll end up having to repeat the injection.
Every pelvis is shaped different, and our body weight and our body size is different. Can we talk a little bit about how that impacts the delivery of care to the SI joint?
Yeah, so I don't think it's typically such a issue for SI joint injections. The one caveat for that would be there's something called transitional vertebra. So at the 6th week of gestation, the lowest lumbar vertebra has to decide, is it part of the lumbar spine that moves or part of the sacrum which doesn't move. And that sometimes there are tweener vertebra, and when they get that tweener configuration, that can be a little bit harder to do an injection, and there's a term used for that called a Bertolotti syndrome. That is the one time where I think that's an issue. Unless it's morbid obesity, in general, the injections can be done relatively straightforward. Interestingly, we've analyzed the effect of body mass index on outcomes in SI fusions, and we've not been able to show a significant difference. Now, we had normal body mass index is probably under 25, 25 to 29 is overweight, 30 and higher is obese, and then we see some BMIs of 40 or 50. And so most of the patients that we included in our clinical studies probably were more in the 30 to maybe 40 range. We didn't have very many 50s. But we weren't able to show a difference between the heavier patients and the lighter weight patients in terms of response to surgical treatment. And that's the first time I've seen that.
That's fascinating, because that's counterintuitive, I think.
Well, so for total hips, total knees, and spine fusions, we know that once you get above a BMI of 35, that leads to more complications and poorer outcomes.
What are the controversies in SI joint fusion? So if someone fails all the conservative treatment, they say, I can't take this pain anymore, it's keeping me from living my life, I'm getting, cardiovascular disease because I'm not moving around, I've got all kinds of issues, I want to have the surgery. What are the controversies around having the SI joint fused?
So there's a number of different techniques, and what I would say is you need to go from point A to point B, and it's far enough that you're not going to walk, so you're going to take a car. So what's the best car? Is it a Ford? Is it a Chevy? Is it a Mercedes? Is it a Maserati? that people have strong opinions, but they're cars that get you from point A to point B. And so that what I try to focus on is what is the best medical evidence. And the best medical evidence to date comes from the lateral to medial approach. There are other approaches that are done. The evidence is less compelling. We'll see if those who advocate that approach can do the studies to generate more compelling evidence. But what I would say is you want something that has reasonably compelling evidence and can be done reasonably safely. And so we've just published a systematic review, and what that means is we've gone through all the literature that reports it out, and we've created a data table to say, what do all of the studies say? And so the greatest weight of evidence is for the lateral to medial approach. That's not saying the others can't work, it's just saying they don't have as much evidence to support them. So it's like the consumer reports say, if you will, that the lateral to medial approach is the best one available to date. And then we're back to the brand preference. And then there is one particular implant brand that's been studied more than others.
But for most people aren't going to go to their surgeon and say, Doctor, are you doing the lateral to medial approach? Because I understand that better, right? So how do patients sort of understand that they're in the hands of a highly trained, highly qualified expert that is confident in the approach that's being taken? How can a patient feel that sense of, I'm in the right place for me?
how many of these have you done? How much follow-up do you do of your patients? What are your results? What is the published literature to support what you're doing? What are the complications? How do you handle the complications?
And do you, as a spine surgeon, when a patient asks you those questions, how do you feel? Do you feel like, great, I'm having an informed conversation with my patient? Or I think sometimes people are intimidated to ask their doctor questions like that because they don't want to make anybody feel bad. They don't want to,
Right, so that's a difficult thing. In a perfect world, you would ask the head nurse from the operating room, if you had to have this done, who would you have do it? Now, most of us don't have the cell phone number
Right.
of the head nurse for the operating room. And that what I would tell you, when you're a junior surgeon just out of training, that kind of a question is more intimidating to you. When you're someone who's been doing it a while, you say, well, here are my numbers. I've done about 350 of these, and my data follows the published literature that about 85% of the time I get a 50% improvement.
Yeah.
And again, I emphasize that if 85% of the time I make them better, it means 15% of the time they're not better, and some of those patients are worse. But that's pretty good for a batting average for a spinal type of intervention. And so it's like, are you bad enough to need it? Does your surgeon know what they're doing? A little hard to clarify, but asking, what would be red flags that would concern me?
This is really, this is helpful.
Yeah, I stayed at a Holiday Inn last night, and I think I could probably do this. I saw it on YouTube, and it doesn't look so hard.
That would be a big red flag.
And the other piece is if the proceduralist doesn't follow up their patients, to me, that would be very concerning.
Yeah. So a patient should expect to come back and see you. If they have an SI fusion, they go home that day, they should expect to come back and see you.
So my treatment regimen post-op is they're on crutches for 3 weeks. Then they go back to see physical therapy to get back to normal walking, because we go through the gluteus medius muscle, which is the outside of the butt, so it's a muscle that sits right here. And they get back to normal walking. Then I typically see them at 6 weeks, 3 months, 6 months, 1 year. And I try to get 2-year follow-up, but if they're doing real well, they generally like,
Don't want to see you again.
why do I need to come back? So.
That means you did your job. So, Dr. Polly, can you show us on Lindsay the anatomy of what you are looking at when you're identifying sacroiliac joint pain versus low back pain, and where, or is it just muscular pain, or all the different kinds of things that can happen that someone comes into your office with pain?
Well, I think the other piece of this, Rita, is that if your doctor doesn't do these things, they haven't done what they need to do to differentiate this.
Okay.
And so we can't do the entirety of the exam, but there's some key points that I do with the patient standing that really help hone in to what's going on.
Got it.
So the first thing I'll ask the patient to do is to point with one finger where you hurt the most. Okay, and so that's called the Fortin finger test. And so Lindsay has nicely pointed to where she has her pain in the butt. So, and that matters a lot. Why? Well, there's a couple of things that we go through. So when someone's hurting in their low back area, sometimes they'll wave their hand over the whole area. Well, that's not helpful in making a specific diagnosis. So I'll tap on the back, does this hurt, and see, and that usually when you get someone who has an acute problem, you tap and they really respond, and you can see, ow, that hurts, as opposed to, it doesn't feel good, but it doesn't hurt.
Yeah.
Okay. The next thing I try to do is there are a number of structures in this area, and different maneuvers stress those structures differently. So a common thing that I'll do is I'll support the pelvis and say, okay, Lindsay, I want you to look back over your right shoulder like you're trying to back up a car. Now try to do a back bend like you're looking up at the ceiling. Okay, back up straight. That loads the facet joint, which is part of the lumbar spine, which is very close in this area and oftentimes can be confused back and forth about which is causing it.
Okay.
And then the next thing that I'll do is that I'll feel the lateral margins here, and that's called the quadratus lumborum muscle.
So that's the QL muscle,
Yes,
right? A lot
yes.
of times people know about the QL muscle.
So it comes from the lowest rib, it comes down to the top of the pelvis. And you can feel side to side, and if one side is rock hard and the other side is soft, that says that there's some spasm going on in that muscle. Most people don't know how to stretch their quadratus lumborum muscle. And it's like having a Charlie horse and not being able to stretch it.
Yeah.
That can hurt an awful lot.
Right.
Okay? And so that's sort of the next step that I do.
People throw their back out taking out the trash or something.
Well, if you're on crutches, this muscle often will go in spasm, or if you hurt your foot and you change your walking pattern, that can
go all the way up to the QL.
it can cause spasm in
Yep,
that muscle.
okay.
All right. So then the next thing I'm paying attention to is this is the posterior superior iliac spine, and oftentimes people will have a dimple in that area, and that is the pain right at the posterior superior iliac spine. If it is, then that makes it moderately likely that it's going to be SI joint. If it isn't, then that makes my mind think in different directions. So here's the posterior superior iliac spine. If it's above the posterior superior iliac spine, I'm thinking facet joint. There are some nerves called the superior cluneal nerves that come across like this, and you can have a neuroma. And so I'll feel across like that and see if they hit a spot. And what I say is, does it feel like I'm tweaking your funny bone? Because if it feels like I'm tweaking your funny bone, that's what a neuroma feels like.
Okay.
Okay.
And a neuroma is an abnormal nerve growth.
Well, it's an abnormal nerve function, and whether it's growth or injury or whatever, there's some debate about that, but it's a nerve that's not happy.
Okay.
So the common things that I see above the posterior superior spine, the lumbosacral facet joint, quadratus lumborum, and superior cluneal nerve. If it's below, then I'm thinking there's a muscle that comes across here called the piriformis muscle. And the piriformis muscle can be tight, and the sciatic nerve comes right underneath it. And so that when that muscle is tight, I tell my patients it's like carpal tunnel of the butt.
Right.
And that it can give them frank sciatic nerve pain from
Interesting.
coming down from that compression. And the way we test that is a seated stretch test. And Lindsay, I'm just going to have you stay there, and I'm going to try to, this is what I have my patients do. So if it's the right side, right leg over left, push down on the knee, lift up on the heel, and lean forward. And if that gives you a fireball in your butt right in this area, that's most likely piriformis syndrome. The treatment then for that is stretching, potential blocks, and sometimes
Myofascial release sometimes on that?
potentially. I've not found that to be as effective.
Okay.
And so it's really the stretching, the blocks, and then in recalcitrant cases, we've even had my physical medicine colleagues will sometimes do Botox to try to help that break the spasm.
Okay, interesting.
The other thing that I pay attention to in this area, so now we get into what's called the ischial tuberosity. When you sit down, the bony part of the butt that makes contact is the ischial tuberosity, and that's where the hamstring muscles take their origin off of. And so if there's tenderness in here, it can either be a bursitis. So what's a bursitis? In the body, when there's a bony prominence and tissues move back and forth across it, there's a lubricating boundary, or like a fluid-filled sac. So that's a bursa. If the bursa is inflamed, that becomes an itis, like appendicitis, tonsillitis, so bursitis. And so that you can actually have a bursitis right there.
On the tuberosity.
On the tuberosity.
Interesting.
And that can be injected, and that can be treated. And so that then gets into almost more the sports medicine type stuff about how do you treat hamstring issues. So that gets me about 80% there, about thinking about what is the diagnosis, where is the pain coming from, and then it requires the provocation maneuvers where we're trying to twist the pelvis to see if it hurts. And then I also will do a loaded test of the hip joint to make sure it's not the hip joint. And thank you, Lindsay, for being a great
thank you, Lindsay.
on that.
Gosh, Dr. Polly, that was amazing. We went over bones, joints, soft tissue, ligaments, muscles, nerves. There's a lot going on. It's a lot going on. That's why it's complicated. It's complicated to figure that out.
So, Rita, what I would tell you is that 20 years ago, this was kind of a black hole topic. Today, there is compelling data that in appropriately selected patients, that this can make a big difference in their quality of life. There are many surgeons across the country who are now trained to do this, and if they're not, find someone who is, and that it isn't perfect, but it's pretty darn good.
That is cause for a lot of hope for a lot of people. And that is what we call the miracles of modern spinal care, giving people options and treatments to get back to their life like never before. And Dr. Polly, we're so grateful to you for the many years of evidence development that you have created for everyone to be able to have these procedures as an option to live their best lives, to live the best quality of life that they can have. And it's thanks to people like you who've dedicated your life to this work that we have these options. And so, on behalf of everybody, thank you.